All right, guys. So thanks for joining us today. How many of you guys were there last night? Okay, so a bunch of you guys were there last night. For those of you that weren't there last night, let me just quickly introduce us. I'm Dr. Mehta. I'm the founder of MedSchoolCoach. I'm an interventional radiologist in Boston. I'm also an associate program director of the interventional radiology program. And basically, I've helped a lot of students through the years match into residency, do well on the boards, get into med school and the MCAT, so all the way back. Today we're here to talk to you a little bit about matching as an IMG, and then we'll also talk about some of the other stuff, like doing well on boards and any other questions you have, choosing a specialty. I want to introduce Elias, who's an SGU student, currently in the match process.
Going through it right now. I have an interview on Tuesday, actually, right when I come back.
So Elias is living proof that you guys can do really well from SGU, right? Which is obviously what everybody here wants to do. So I thought would be interesting for us to do is me to kind of ask him some questions from an SGU perspective, or even an international Caribbean medical graduate perspective, what it's like to go through the process, specifically at SGU and then also as an IMG. And then for you guys to ask questions, then also for Elias to ask me questions as a program director, how I view international candidates and what we're kind of looking for students who are looking to come back. So maybe I'll start off by can you tell us a little bit about the experience that you've had as an SGU student and applying for residency?
Sure. So, applying for residency as an IMG, I will say that as a Caribbean medical student, in terms of the other Caribbean schools like Ross, SEBA, and AUC, AUA, those guys see you guys as like, oh my God, the top tier school in the Caribbean. So whenever I'm on the trail and I meet someone from Ross or from any of those schools, I always tell them about SGU, and they're always like, oh my God, you guys have it so great. And I think to myself, really? We had it great? But coming through and talking to program directors, it seems, from a radiology point of view, it seems that there is a shift in the dynamic where people are starting to, understand that IMGs, that these schools do produce, good physicians, and there's not really a distinction between the Caribbean MDs and the DOs, right? So the program directors aren't caring as much as where you went, more as, are you a good candidate? Are you going to be a good doctor? At least in the radiology point. Now for me, I do get a little bit of stigma, and it's not intentional stigma. It's just like, oh, you went to SGU, how was it living in paradise? And I'm like, well, and then obviously,
Paradise, right?
It is paradise, but in reality, as long as you have the confidence in yourself when you're talking to the program directors and you're in your interviews, and you know that you're going to be the best candidate, right? It doesn't really matter where you went, right? So overall, the experience was pretty well. It went pretty well. I never felt like I was discriminated against. I think that if you have the correct resume and you have the right scores and you do all the right things, that you can get interviews anywhere.
So let's take one step back, right? Because a lot of people in the audience probably are wondering sort of how do we even choose a specialty, particularly coming from SGU where your clinical rotations obviously are, you don't have much exposure to clinical medicine on the island, right? It's like you have exposure to a lot of basic sciences, but you don't have exposure to different specialties. That's a little different than US med students who get from the first and second year, can go shadow an ENT, can go shadow an IR, can go, see what ophthalmology is all about, can go see what pediatrics is all about. I think you have limited opportunities to do that here. So how, as an SGU student, do you kind of go through the process of even choosing a specialty?
Right, so I'm sure they told you at the career fair, they said that there's like a questionnaire that you can fill out that'll tell you what kind of specialty. So it told me to do surgery. And I was like, there's no way I want to do surgery. Now that questionnaire might work for you. So I always wanted to be an oncologist. I always thought that I wanted to do hematology oncology. I thought that was just what I wanted to do because, I've seen, because I have family members, we've all had someone that's been affected by cancer, and you see the oncologist and you're like, that's, it's a great job. And then when I got to my elective rotations, I did one at the Mayo Clinic, and I did a hematology-oncology rotation, and I said, I hate this, I don't want to do this ever. And this was about 3 months before the residency applications opened up. So I'm like, oh crap, what do I do now? So it kind of stumbled on a surprise that I found interventional radiology. Actually shadowing a radiation oncologist, I saw an interventional radiology procedure, and I absolutely fell in love with it. So I'm a special case, but for the general consensus, yeah. So the general consensus is you first want to kind of think about, like he was saying, you don't really get much exposure to clinical medicine yet, but you have to ask yourself, am I someone who likes to work with my hands, or do I not want to do procedures at all? Am I someone who loves talking to patients, or do I never want to see a patient ever, right? Am I someone that wants to know a little bit about everything, or do I want to just be really, really good at like one small field? So those are the questions you got to ask yourself. But most of the kids that come out of SGU, right, they go into internal medicine, and then from there you can specialize, which is a great, it's a great choice to do that, because the options are limitless. You can do fellowships in anything, cardio, GI, hem-onc. But those are really the core questions you want to ask yourself, right? Do I want to work with my hands? Do I like talking to patients? And do I want vast knowledge, or do I want like specialized knowledge? That's what I asked myself. And I said, I like procedures. I do like talking to patients, but not too much. And I like to have a pretty vast knowledge. And I think interventional radiology kind of, hit the nail on the hammer. With the hammer. Hit the hammer with the nail. Hit the nail on the head. Having a brain fart, excuse me. So yeah.
So I think what's important for you guys is if you're coming from an IMG background and you want to do a competitive specialty, right? Something maybe that's not internal medicine, something that's not family medicine, and you even have an inkling of that, pursue it early, right? Even while you're here on the island, which is to say, maybe during your breaks, go back home and really find out, okay, is this really what I want to do? Because if it is what you want to do, then you really have to plan, I think, differently as an IMG than if you were to apply to, let's say, family medicine or internal medicine, like places where there's more spots. So if you're interested in a competitive specialty, think about it earlier and make sure that you are really positioning yourself for that, right? Because you're gonna have to plan your fourth year AIs in a really advanced fashion, right? You can't wait until the last minute and then expect to all of a sudden have a spot open up in a sub-I in interventional radiology and be able to do it. It's very hard. So the earlier you plan, the better. I think understanding, okay, am I a surgical person? Am I a non-surgical person? Is like one of the very first steps that you guys can take very early on. But it's hard. Like I always tell students that choosing a specialty is the hardest thing you could do. It really is, because who knows what you want to do? I mean, you guys aren't exposed. So, and you have more limited exposure than most students being on the island. So take your breaks as you go back home to maybe even like shadow more people, see more specialties to really understand what makes sense. I got a question for you. Did you use or did you know about charting the outcomes and that resource when you were planning sort of how you were going to approach this?
So SGU does give you a good amount of information on their website for the NRMP. They give you a lot of information. The NRMP has all these statistics and data that are kind of hard to understand, but if you really take a look at it, it really tells you which specialty and what average step score you need to have, how many publications you have to have on average, how many contiguous ranks. So I definitely use that when looking at radiology per se. Since IR is such a new residency, there's not a lot of data on it because there's only about 5 or 6 years of data worth. But I definitely use the NRMP, and I would start looking now and trying to set your goals now, because if you wanted to do derm, the average dermatologist has to have 10 or 15 publications, so you need to get a move on, right? So I would definitely start looking at that as early as you can.
Do you guys know what charting the outcomes is? No.
Okay, so let me explain. Basically, so charting the outcomes, so the NRMP is basically the program that does the match. So when you submit a rank list from your residency application, you rank all the programs that interviewed you, and then they rank their interviewees, and then basically there's an algorithm that matches you to your program. Now, in your application, it has a bunch of data, your step scores, your publications, how many contiguous ranks that you rank. So if I ranked 10 IR programs in a row, that gets charted, and it basically will tell you all the people that match into this specialty. This was the average step score, this was the average amount of publications, this was the average step 2 score, this was the average this, and it's all on nrmp.org. If you type in nrmp.org and you type in charting or charting the outcomes of the match, and you can look at last year's match in 2018, all that information is there on one big PDF.
Yeah, so this PDF is gold. It really is. And you guys should look at this to set your goals, just like Elias was saying. You really need to set your goals and your expectations, right? So if you say, oh, I'm really interested in ENT, let's take a look and see what's the average board score, how many people, it actually breaks it down. It'll show you okay, people with a 250 to 260 or 240 to 250 or 230 to 240, how many people applied, how many people match, and it actually does that for US graduates, and it does that for IMG. So it's actually the best PDF that you can find, and so we'll send you a link to it, but you should definitely look at that, and it'll help you sort of set the expectations of what you need to get and set your goals, right? Because your goal might be, oh, hey, I need to get that 240, 250 in order to be competitive for this specialty, or hey, maybe I don't. Maybe I'm doing just fine with my, hopefully 230, 240. I'm going to be okay because I'm looking to match into internal medicine.
And I actually had a question for you. So, being an associate program director, when you see someone with an IMG status, is there anything else that you're looking special in their application?
So, and this is a great question. I talked to a couple of people about this as I've been on the island, which is like, how do programs evaluate an IMG, right? Like, what do they look for, and is there a stigma? Is there not a stigma? How does that work, right? And I'll tell you, the long answer is that, or I'll tell you the short answer first, which is there probably is a stigma. Sorry, like there's a stigma to being an IMG. Now, does that limit you? No, not necessarily, right? Which is to say that if you have really good scores, if you have research, if you come on a sub-I and do really well, I absolutely do not care where you went to medical school, right? So if you can make a good impression on me, then I don't care where you went to med school, provided, of course, you've passed and done well on the step, et cetera. Now, that actually holds more true the further along you get, right? So, for instance, if you're applying for a fellowship after residency, your med school matters even less. Once you're applying for a job after fellowship, your med school matters probably not at all, really. And so as you move along this process of going through the residency match and then the fellowship match and then eventually looking for jobs, it's actually going to become less and less important where you went to med school. One of the sort of preeminent people in my field right now, interventional radiology, is an international medical graduate. He publishes every single day, publishes a ton of papers, is one of the leaders in prostate artery embolization, does a ton of stuff, and we all respect him and have no idea where he went to med school. Now, I know because I'm just interested in this stuff, but it really doesn't matter. I mean, the guy's a genius, he's brilliant, and he's one of the leaders in our field. And that's what you absolutely can become, but you have to obviously get over some hurdles to get there. First hurdle is getting into that match. So we do, I think the things that I look for, I'm definitely going to look for a step score. I'm definitely going to look for great clinical work, and I think that the way you can really show that is by being present, right? Doing those AIs, having great letters of recommendation from people that I may know or the program director who's evaluating may know. Those things will go a huge way in proving that as a SGU graduate, you are on equal footing, if not better, than a lot of the US medical candidates, which is what you want to end up doing.
And to speak on that a little bit, and for how many people are in term 1 here? Just you, so how many people are term 5? So you guys are going to be going to, this is for everybody, but mostly for the term 5. So when you get to your rotations, immediately start thinking, do I want to do this? Because if you do, you need to make a good impression on your clinical coordinator, on your doctor you're attending, because those letter of recommendations go such a long way. Because on paper, you might be exactly the same as somebody else. So how are they going to differentiate? Well, they're going to look at research, they're going to look at extracurriculars, but they're going to read your letters. Right, and the letters go a long way. So when you get to, this is obviously post-step, but when you get to rotations, really make sure you do the best you can to impress your doctor that you're working under, because those letter recommendations really will make or break your application.
And the ability to do rotations at places that have residencies,
yeah,
I think is huge. And I will ask you this question: how many of the hospitals that you guys rotate at actually have a residency program of some sort associated with it?
So I would say about 80% of the hospitals that are affiliated have residency programs, especially the ones that offer electives. So a lot of our cores are in New York and New Jersey, and yes, they have residency programs, but we do have affiliated hospitals. For instance, we have the Cleveland Clinic in Weston that offers pretty much every single thing that you could want. The IM, family, peds, psych, surgery, even orthopedics, everything. So it's very important to do rotations at places that offer the residencies, right? Because then you get to meet the people, and if you come back for an interview, they already know you, right? And that's just, you're just one step above all the people who they just know on paper.
Yeah, it's huge to do your rotations whenever possible at a place that has residency programs. If it has a residency program and what you want to do, that's your ticket in. That is your ticket into that school. When you look at SGU, do they provide a match list of people who've matched and where they've matched to?
Have you guys seen the match list? Right, so you've seen it. So don't forget that, don't just look at the PGY1s. you want to look at the PG, so you can click on the tab that says PGY 1, 2, 3, 4, 5, because some people in PGY 1 might be just matching into a preliminary position, like a surgery prelim, medicine prelim, or transitional year. You really want to go to the PGY 2 because some people might have matched into like anesthesiology or radiology, like residencies that require a prelim. So the PGY 1 doesn't give you the full story, so make sure you click on PGY 2 and kind of go all the way through. We did have one person match into Uro, actually, because urology does a early match from my class. So that's, like I said, that's great. Urology is a very competitive field. So like I said, it's definitely possible. But they do, to answer your question, they do provide the match list. Definitely take a look at that study, and not only study what people are going into, but where they're getting into, right? Look at those hospitals and be like, I need to be close to that hospital. I need to, go look at that hospital, look up the program director, look up what he does or he or she does, right? You need the more information you know, the more equipped you are to be successful.
So obviously one of the great things about SGU is that you guys graduate the most medical students every single year, right? Which actually means you place the most people in the match every single year, which means that, you're the school programs that take SGU students will take SGU students again, right? Because the people who match and the people who've gone through typically are going to do really well, right? And they're going to be good clinicians, they're going to be good students. And so as long as they've had good success and good experiences with the past SGU student, they're going to take the next SGU student. And that's actually huge. And it actually works, unfortunately, conversely as well, which is that if they've had a negative experience taking a student from any international school, they will not take another student from that international school again. And it kind of stinks, so suck up to your upperclassmates and make sure that they're really, really doing well when they get to residency, because that's what's going to help you tremendously as you get there.
I don't know if you guys ever saw that video. It was a few years back, and there was a lady coming out of an Uber, and she started screaming racial slurs at the Uber driver. And then she was actually a neurology resident at the University of Miami. And when that went viral and it went on the news, they kicked her out of the residency and they said, no more SGU students. They said, no more Caribbean medical students. So it takes something just like that, and you could really ruin it for pretty much everybody. So not that I'm saying you guys are going to do that, but as Dr. Mehta said, the people who precede you and the people who come after you are just as important to your success as well.
Yeah. So unfortunately, that goes to the stigma, right? So that goes back to saying, yeah, there is a stigma. If that person had been from, University of Miami, they wouldn't have said no more University of Miami students, right? Like that's not the way it works. So there are hurdles to overcome, but you can overcome them. There are external hurdles to overcome, like your classmates ahead of you that you still have to overcome. So all this goes back to, listen, you can do really well, you just have to work doubly hard. And that's okay. That's what you guys are all ready to do and I know equipped to do. Can you explain a little bit about the match process? Because I'm sure people are kind of confused about like what does match even mean? What is that word?
The basic timeline, because I know there's a lot of information out there that it's kind of hard to piece together, so I'll give you the basic timeline. So you'll start in term 1, your basic sciences, and you'll finish in term 5. And then hopefully about 7 weeks after you finish term 5, you'll take your step. Then, barring you pass the step, you'll begin rotations in the next cycle, right? Wherever place you get matched. Now, in your 3rd year, you'll be doing your core rotations, right? So that includes internal medicine, surgery, OBGYN, psych, peds, family. So that consists of your 3rd year in which you'll take your shelf examinations. So those shelf exams are important because that goes on your transcript, and then your core examinations, the way they describe you in your rotations goes on your MSPE, your Dean's Letter. That goes into your ERAS application. So at the end of your 3rd year,
and just a quick note on the ERAS application and the Dean's Letter. I talked yesterday about how your preclinical grades mean nothing, and that's true. But your Dean's Letter actually does mean something, and that is something that we utilize as program directors to evaluate students from within a university. So every Dean's Letter has specific language that they use, and they may say, Elias makes a good candidate for residency. I know that's code for, not so good. Elias makes a fantastic candidate or an outstanding candidate, etc. And some even go as far as actually ranking the student on a quartile or even a percentile range. And so if there's 3 SGU students who are applying to my residency or 10 SGU students who are applying, I'm going to use that Dean's Letter as a really good filter to understand where that student stood within their class, and that's all based on your clinical grades.
Right. And you'll be assigned a coordinator for your dean's letter up at the middle of the end of your third year. And you and your coordinator will kind of talk about like what they want to put into the dean's letter, like anything extraneous that they don't know or don't see on your application. So at the end of your third year, you're going to start studying for your Step 2 CK, and you're going to take your Step 2 CS, right? And in the CS, you can take Atlanta, Philadelphia, Chicago, or over in LA. And barring you pass those two, you're going to set up your fourth year electives on whatever you want to do. So if you want to do emergency medicine, you'll be doing that. Now on this point, at the end of your third year, beginning of your fourth year, you're going to ERAS is going to open up in September, right, of your third year, and you're going to upload all of your stuff into the residency application portal. And then I think on, what day does it usually go out? Does it open up for, I think it's just September 15th that the programs get it.
Yeah,
so,
I believe September 15th is the day that program's actually.
So you can actually, so you'll fill out your application, and then on September 15th, it's available to all the programs. Okay, and then immediately after that, once your letters of recommendation are uploaded, right, through ERAS, programs will start sending out interviews. And you'll schedule your interviews from November all the way to like February, right?
And interview scheduling and that process is unfortunately a mad scramble.
It's a headache and a half.
So
it
you
really
have to
is.
be really ready during that time to book tickets fast, jump on available interview dates, and then have flexibility in your tickets, because there's no
Exactly.
doubt that you're going to go and cancel one and get another interview somewhere else and go get that at some point down the line. So that's going to happen all the time as you go through this, through that process.
One little quick tip before I finish about the rank list and the match process is get a frequent flyers account from somewhere like Delta, American, and start building up miles now, because I can't tell you like how expensive the interview process is. It's very, very expensive. But I reached like Delta Silver just from flying in like 2 months. All those flights I made like medallion status. And also, I mean, this is obviously for the future, but make sure that like you're checking your email every 10 seconds, because once you're given an interview, if you don't respond quick enough, they might send it to somebody else. And I'll give a quick anecdote story. I was given an interview. I came off the plane and I had a missed call like from the hour previous. And it was 4:55 when I landed, and I called her back. She said that she was coming out of the office and leaving, and she heard the phone ring and turned around and answered it and gave me the interview. She said if I had been any bit later, she would have been out the door and I would have missed the interview. So that's how close it gets. So just to continue, so you'll be interviewing from around November to February. In the month of February, your rank list will open up, and you'll rank all the programs that you interviewed at, right? And then those programs will subsequently rank you. And then the algorithm, matches you to your program, and then March 20th, right, you match. So what happens is on Monday, you get a letter of that week previous to March 20th that said that you match. It doesn't say where, it just says that you matched. Because if you didn't match, then you could end up going into the SOAP or the scramble. And then that Friday, which is March 20th, you actually get the email that says you've matched at so-and-so and such and such. Yeah, it's very nerve-wracking. You can imagine I'm literally about to be there in a couple months. And then you graduate, and then you literally start working in July or August of the next year. So
it's a really nerve-wracking process.
Yes.
That's absolutely true. And it's nerve-wracking across the board for any student in any specialty at any medical school across the country. Obviously, your goal is to get that email on Monday that says you've matched, and you could breathe a sigh of relief, because wherever you're going to match, you've matched. Like that's what really matters, right? As soon as you get that residency, you're set and you're golden. Now, the match process works always in the student's favor. Do you guys know about ranks and how the match process works? So basically, always the way it works is that you're kind of dating the programs. And the programs, you're deciding which of those programs you want to marry, all right? The programs are dating you as well, but they have less say in who they want to marry. So basically, if Elias, let's say, interviewed at Harvard, Yale, University of Florida, Emory, and USC, and he decides that USC is his number one choice, he would rank USC number one. Now, USC has interviewed 10, 15, 30, 40, 100 students, and they're going to do their own rank list and decide who's going to be on top. And Elias may end up being like their 20th ranked person. That means that they want 19 people ahead of him. But if those 19 people wanted another program ahead of USC, they'll match into the other program first and kind of fall down to him. So it always works in your favor, which is nice. as a student, you don't really have to play games with it. You should really just rank who you think, where you want to go. Like that's period where you want to go. A lot of people think you have to play games. Oh, if I rank this one number one, will they rank me number one? No, at the end of the day, it's all about sort of what you want, and you just rank in the order that you feel like you want to go in. Now, can you talk a second about applying to 2 specialties? Because I think a lot of people, particularly coming from international and SGU, may be applying to 2 specialties, and it might be a good idea.
So I actually applied 2 specialties. I applied interventional radiology and diagnostic radiology. So it used to be that diagnostic radiology, you used to do that residency and then did a fellowship in interventional. And then in the past 5 or 6 years, interventional became its own residency. So you can get into interventional through diagnostic, which is why I applied it as a backup. So it's kind of a special case, but for most people, like from SGU, they'll be applying internal medicine, and then they'll be applying like psych or family medicine as a backup, right? So I always recommend having a backup specialty, no matter what. And my backup specialty is diagnostic radiology, right? So if you're applying, internal medicine, you should really think about, should I have a backup specialty in family? Like, should I apply to, some programs in family medicine just to make sure? Because matching in like the worst place is still better than not matching, right? So you always want to have a backup, right? So like I said, for internal, I would recommend applying, family medicine, or psych, or if you have anything, or peds, anything that you'd want. Just keep that in the back of your mind. And I just think, just however much you can increase your chances of matching, because you don't want to not match, right? So always have a backup.
So the backups are typically the less competitive programs,
Right.
obviously, right? So the more competitive programs you have a less shot of matching into, so you maybe apply to that as your primary sort of target, and it could be something that's far-flung, or it can be something that you're kind of confident you're hopefully going to match into, but having a backup, I think, from a international background is good. And your backup should typically be a program or a specialty that accepts a lot of international students, that has unmatched spots every year. So, which is to say that, hey, they have more spots than they have applicants for, or they have ranks for, so that they want somebody in their program. They would rather have a warm body than nobody at all at the end of the day.
Now, don't make your backup like plastic surgery.
Doesn't make sense.
But if you were applying plastics, your backup would be general surgery, right? So that's how it works. Question.
Yeah, that's a great question. And so all that data, thankfully, is on that NRMP, charting the outcomes. It actually has so much data, you're going to blow your mind by looking at it first, and you really have to digest it. But basically, one of the tables goes through how many people applied, both US and international, how many spots were matched, how many spots were unmatched. And so it's an easy way to understand, okay, which specialties have unmatched spots. Now, in general, and this is a generality, it changes a little bit from year to year, but programs like family medicine, psychiatry, pediatrics, these are some of the quote-unquote pathology, quote-unquote easier programs to match into. Now, it doesn't mean it's easy to match into. It doesn't mean that phenomenal students don't go into those programs, but they typically have more available spots than applicants, and so those are used as backups. More competitive specialties, IR, plastic surgery, dermatology, those are on the spectrum of like, hey, we have a lot of students who go unmatched every single year, including US students and definitely a lot of international students. And then there's a big swath in the middle. OB-GYN, emergency medicine, those things are sort of down the middle specialties where we're about even. We have about the same number of people who apply, or is about the same number of people who match. And that NRMP charting the outcomes gives great information on that.
Great. Question.
For my case, I am going for psych, which is one of those less competitive ones. Is there any way what should I do if it is less competitive? Is there anything that I need to do that is extra to make me stand out in that field, or what would you recommend for that?
So psych is a very heavy field in research, right? So as soon as you get off the island, or even now, you can try to get your name on some papers, right? Obviously excelling in your psychiatry rotation, getting great letters of recommendation, and doing elective rotations at places you want to go to. So where are you from?
Bay Area.
So California, historically has been a little less IMG friendly, but it's actually, getting a little bit better. So, we do have Florida, we do have associated hospitals in, I think it's Arrowhead is the one that we have. Yeah.
There's one in Oakland.
And there's one in Oakland too. So definitely do, elective rotations there if that's where you want to match, right? So that's great. But it's really, for psych, it's really just doing, the nitty gritty, making sure that you get all the basics covered, getting the good letters, getting the research, and then doing the elective rotations. Yeah, so it's not going to be, so SU doesn't really do a good job of, finding research for students. So I actually had to go out of my way to find research opportunities and write papers. So that's going to be how I would recommend. So once you get to the hospital, right, you can just start asking, hey, are you guys writing any papers? Hey, exactly.
Yeah, so I think that, that question gets to a couple of points, and it's psychiatry independent, which is how do you separate yourself once you get to a point where you have a USMLE score that's going to be looked at, right? So we talked yesterday a lot about how USMLE score is super important, but now let's say you have that USMLE score and you're where you need to be, right? How do you break yourself into that field that you want to get into? Research is extremely important in the field. And research is important because it shows interest in the field, right? So if I have an IR candidate, if they have done research, if they've done publications, if they've done things, then I know that they're really, truly interested in IR and maybe not applying as a backup and just throwing an application out there, right? So research is a great way to do it. Obviously, sub-Is and advanced electives are another way to do it. Also, extracurriculars are relatively less important, definitely way less important than they were to apply to med school. But if you're part of, let's say, the psychiatry interest group or the president of the psychiatry interest group, like that kind of stuff does go a little bit of a way for me to say, okay, hey, that person is truly interested in this field and has been interested in it for a while. So those are some of the things that you can do along with obviously the letters and those kind of things.
And just to speak on that, I know it's a little early for you guys to know what you're going to do, but really try to get an idea. Like when you guys go home on break, start looking around if there's shadowing opportunities. If you want to go to a hospital and ask some doctors, like if you want to be a cardiologist, go shadow a cardiologist. If you want to be a neurologist, ask around, go shadow one. Because everyone, I think when I was in med school, everyone thought that neurologists were these Einstein brainiacs that were walking around the hospital. It was and then when I saw neurologists, I'm like, oh, these guys are just, the really chill guys going around and treating stroke patients, right? So, there's a lot of things that you might see a specialty as, but once you really get into it and see how their day-to-day goes, you might say, I could never do that for the rest of my life. Or on the flip side, you could say, I would love to do this for the rest of my life. So, the more information you know and the more you plan in advance, the more successful you'll be, right? So I'm not asking you to, know 100% what you want to do right now, but what I am telling you to do is, and I think this goes for everybody, is just make sure you have an idea of what what you would want to do so that you can prepare yourself and make yourself successful in the future. Question?
So you mentioned having a backup specialty or something?
Yeah.
Applying, is there a limit to the number of specialties you can use?
It's the limit is how much money you can pay for the application. So the application can get pricey. The more programs you apply to, the more it costs, right? So you have to think of a kind of a cost benefit of would it be worth applying to 300 programs, right? Because then you have to think about if I apply to 300 programs, what if I get 30 interviews? Right, that's definitely a possibility in family medicine or internal medicine. It's quite possible to get that many interviews if you apply to that many specialties. So it really comes to, you have to get all of your basics together. You have to get your step score and all your stuff and what you want to do and where you want to go and what region. It's kind of like a whole algorithm, but there really is no limit.
So, so there's no limit on the number of programs you can apply to. There's no limit on the number of specialties you can apply to. So in theory, you could apply to every single specialty, every single program, and see where you get interviews. And then even when you rank it, you don't actually have to rank it by specialty. So you could say, you know what, I really want to go back to the Bay Area, so I'm going to rank Arrowhead Internal Medicine number 1, Arrowhead Psychiatry number 2, and then I really would rather not go to Kentucky, so Kentucky Psychiatry is going to be number 3, right? And so it's all, you can actually rank it by geographic location, you can rank it by specialty, and it, again, will just favor you, and it'll just go wherever you decide. So you can rank multiple specialties contiguously, essentially. Now, the question of how many programs should you apply to, particularly from SGU, is a good one, and there's really no direct answer to that. Because if you're applying to plastics, well, you got to apply to every single program in the country, period, end of story, right? If you're applying to internal medicine and you apply to every single program or family medicine, now you're going to be overwhelmed with interviews and you're going to have issues scheduling all of them. The nice thing is that there's no extra work in applying to programs. There's just extra money involved, but it's essentially just a checkbox. You check it off, it goes, right? That's it. Like there's no secondary essays like there were for medical school. None of that stuff. Actually, well, I'll say that there's a few programs who've introduced residency secondary applications, but that's very, very few. The reality is most of them you just check a box and the application goes there. Now, the problem comes in when you get all these interviews, and let's say you schedule an interview and now you get a better program or a program that you'd rather go to. Now you're turning down an interview and reshuffling it, so it becomes a little bit of a nightmare and a headache. My general philosophy, particularly for a international grad, is plan, 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 and make sure that you're planning to fail. Like, make sure that you have a plan in case you don't succeed, right? Which usually means applying to more. Now, there's a pamphlet you guys have called For the Match Your Resident, which is a nice program. It's a computer program that allows you to actually think about these kind of things and actually think about, okay, I'm an IMG, here's my scores, how many programs should I apply to, what kind of programs should I apply to? And then we, as residency advisors, can help you do that as well in a non-computerized approach, but a human approach to really understand, hey, who are you, what are your scores, what are you looking for, what are your goals, let's choose how many programs to apply to, and let's try to figure that out.
So I know that the DO, there's an agreement now.
Yes.
Right, but the DOs are now going to be coming in and being able to apply for pretty much every residency program. Is there, have a perspective of how that's going to affect the IMGs when we start competing?
Yeah, so the question is about the merger. That's the colloquial name, the merger between DO and MD, and how that's going to affect IMG candidates, right? And I think that unfortunately, there's going to be more candidates, obviously, for every single position across the board, or more applicants for every single position across the board, because osteopathic is going to be very easy to apply to. That said, I don't think it's actually going to change how programs look at IMGs, nor the candidates that they normally look at. It's actually going to affect more the osteopathic specific programs that may get MD candidates. So you're going to get a little bit more competition, but in general, it shouldn't affect how you approach anything, right?
Except for like orthopedics, where they might have like more of an emphasis because of the osteopathic part. You would say that those would be more crowded specialties to apply to?
I think all specialties are going to get all programs are going to get more crowded because you're just going to have more people in there, but the number of spots at the end of the day stays the same, right? There's not an increase or decrease in the number of overall spots. So I think a lot of the merger stuff is not overblown, but it doesn't actually change all that much. Like we get osteopathic applicants to our program all the time right now, regardless, right? They've taken the USMLE Step 1, Step 2, just like anybody else. Now, keep in mind, osteopathic physicians and the DO also maybe has a slight stigma to it, right? I put stigma in quotes because at the end of the day, that's all it is. It's a stigma. It doesn't mean you're a worse doctor or anything along those lines. It doesn't mean that you can't succeed and do exceptionally well. But there is some, something in the back of people's head that they look at a DO and they say, okay, would I rather look at an MD? So, that probably plays in your advantage a little bit as an international grad because you have the MD. But listen, at the end of the day, it's all going to come down to doing well on your step scores, making a great impression on your rotations, and that will overcome any merger, any stigmas, anything else that's there.
So fourth year, you're doing interviews and elective rotations. Is there ever a time where you're in an elective and you have to leave for like an interview?
Yes, all the time. And most of the time, you have to I brought my schedule to my preceptor, and I was like, these are the days of my interviews. Like, let me know if you want me to make these days up. And most of the time, your preceptors are, understanding and aware that, students have to go on interviews. Now, don't ever lie and say you have an interview and not go to your rotation, because if they have any suspicion that you're lying, they will check and they will mark you down. And I know people specifically and personally that have done that, and it really put them in a bad spot. So don't ever think about doing that, ever.
So programs are, obviously very considerate and know that during your fourth year, you're going to be interviewing for residency, and that's not your main goal, but that's your goal at the end of the day. Your goal during the rotation is obviously to care for patients, get an understanding of that specialty, and be a good student there. So I think exactly what Elias said, which is if you go ahead of time and be proactive and kind of talk openly and honestly with your program coordinator or director or whoever's running your clerkship, they will always be very accommodating for that in 99.9% of cases. That said, if you are, let's say you really want to go and match at, I'm going to say Brigham University Psychiatry, right? You should try to do that away elective probably in August before you have any interviews, right? Don't save that for October or November where you're going to be away for 4 out of the 7 days or whatever it might be. Like, that's a bad idea. So you should plan ahead of time and understand, okay, I really want to match into this program. Let me go do that first when I have nothing else committed, because for me as a clerkship director, I want to see that that student is extremely committed, that is there. You want to have as much face time as possible, and you don't want to keep going to them and saying, well, I got to kind of skirt out, I got this interview. So plan accordingly, which is to say, save your advanced electives that maybe you're less interested in or have more flexibility later on, right? November, December, January, when the bulk of residency interviews are going to be.
You have a question?
In terms of the order of the core clinical rotations during your third year, do you have to go in the order that SGO gives you, or can you customize it? And for example, if I want to go into radiology, would I be able to switch out family medicine for radiology during my third year so I can get a letter of recommendation?
You can do family whenever, but the cores I think are scheduled by the school, and that's set by the school. But family is one of those cores that you can actually do. I know people who are doing family now in their fourth year. It just has to be done. It doesn't have to be done in your third year. But in terms of your actual third year schedule, I think that, and I could be wrong, but I'm like 90% sure that once you get the schedule, it already kind of tells you what you're going to do. And I don't think there's a lot of leeway to that. But then again, if you talk to your clinical coordinator, I'm sure that they can move you around. But the course have to be done in your third year, right?
So that goes to the question of how do you overcome that hurdle, right? And like get a good letter of recommendation or get exposure to a specialty that maybe you don't have a chance to. And this is not actually just a SGU or an international medical graduate problem. This is a problem for US Med students too, that they have a bunch of courses or rotations that are scheduled, and it's very hard to change out of that and find elective time. I would say that if that's why it goes back to thinking about this early. If you know there's a specialty you're perhaps interested in, you're going to try to do everything to rearrange your schedule around it. On top of that, when you go home, you're going to go and get some exposure to that. You're going to do research maybe over your summer with somebody who's interested in that field or somebody who's in that field. All those things will give you exposure, give you the good letter of recommendation early. So like in anything in life, planning ahead of time and sort of making some of those decisions is going to be super important. That's not to say you can't change later on and you have to make all your decisions in term one about what you want to be. That's impossible. I went into med school thinking I was going to do pediatrics, and then I thought I was going to do ophtho, and then I thought I was going to do ortho, and then I thought I was going to do rad onc, then I thought I was going to do emergency medicine. And so, I mean, this isn't like in a span of 6 months I went through all those specialties, and it's going to continue, right? You're just going to, it's an evolving process. But I say plan for the most competitive, the hardest thing to do, and then you can work your way backwards.
And like I said, I changed 3 months before the application process opened up.
I was worse. I was going to apply to ophtho while applying to radiology when I went through it. So during the match process, I was still confused. And I was actually going to apply to ER too, because I did a couple of ER electives and I decided, I really like emergency medicine. So it's, and this was literally August of the year that I was applying to residency. So it's hard, right? This is a hard thing to do. Unfortunately, it becomes somewhat harder for SGU students just because you have limited access to some of the rotations. So you're stuck between a rock and a hard place in some ways, but again, like planning ahead and kind of being proactive about it is the best way to counteract some of that.
Going back to research, exactly what kind of research opportunities should we be looking for?
Any. Any. You can do anything from like a case study to any kind of like digital presentation to even a presentation you just give to your preceptor. You could put that on your ERES application, or you could get on a big bench work, scientific research center and getting a name on a huge paper. Any research is better than no research.
And you have time to do that during your rotation?
Yeah, you do. It's a struggle to find IR research because the IRs at hospitals are usually kind of aloof. Like, you don't really get to talk to them that much. At least at the hospitals I was rotating. I don't know how it is at the BI, but at our hospital in Atlanta that I was at, like you never saw the radiologist because they just were never around. So, but for like psychiatry or internal medicine, right? There's probably people writing papers all over the place. So you could definitely, even if you just ask them, hey, can I go crunch the numbers for you, right? They'll put your name on the paper. right? So anytime you can get your name on something, anytime you can get a presentation, or anytime you can do anything, it shows that you're interested in the specialty.
Yeah, I mean, this goes back to obviously there's different types of research, right? There's basic clinical lab work research, there's clinical research, and then there's things like case reports and abstract presentations and educational exhibits. Really, the spectrum is fine. You can get on anything. The lowest hanging fruit is something like an educational exhibit, for instance, at a national conference. Like, that's very easy to put together. It doesn't take a lot of time. All you need is a preceptor or mentor who's willing to kind of work with you for a little bit to walk you through it, right? So you should definitely do that. Then there's a little bit harder, like a case report. It takes a little bit more time. You have to think about it, you have to write it up, you have to understand it. Then there's more, which is like actual clinical work, and then there's a lot of work, like basic science work. So we just kind of went backwards in that spectrum. And so the easiest thing is, these educational exhibits, these abstract presentations, and they absolutely make a huge difference. And so anytime you have the opportunity to do that, and look proactively for the opportunity to do that, right? Like, seek out the opportunity to do that. It might be that, let's say you're interested in IR, right? You should go as a third-year medical student to the Society of Interventional Radiology Conference, which is held every year, right? And you should see, okay, what kind of educational exhibits are here? What can I do next year? What can I put in? It's typically not a lot of work to put some of these things together. If you're interested in oncology, you should go to the ACO conference. If you're interested in internal medicine, you should go to the AAM conference, right? So these different things that you can go to during as a student, which, by the way, as a student, they're always typically free, and so you can go and just walk around, get an idea, and then find a mentor or a preceptor, and you just say, hey, listen, I want to put this work in. Can I do it? And almost everybody will say yes, absolutely, because the reality is we don't necessarily have time for it. I don't have time to write an educational exhibit, but I definitely have residents and fellows and students who are interested in doing that, so I let them do it, and I just kind of sign off on it, and I guide them and mentor them through that process.
And also, your hospital, some of them will have like research departments that you could just go in there and be like, hey, like what's going on at this hospital right now? You can just, sneak your way in there, right? So any research, and as Dr. Mehta was saying, any research, anytime you can get your name on something, it helps. Question.
So why do some people have to take a step 3 and some people don't? And can you still apply to residency without step 3?
Yeah, so basically the way that the steps work, for those of you guys who are unfamiliar with it, is step 1 is typically taken after your preclinical years, right? It tests basic science knowledge. Step 2, CS, which is step 2 clinical skills, is a OSCE exam. It's a standardized patient exam which tests your clinical skills, your English skills, your ability to interact with patients. Step 2, CK, clinical knowledge, is a clinical knowledge test. It's an extension of step 1, more clinical vignettes, more things focused on surgery and medicine. And then step 3 is sort of your last hurdle to becoming a licensed physician. It's not a board-certified physician. It's not a physician that can necessarily practice anywhere, but you're at least licensed to practice. Step 3 is taken after intern year. Okay, so step 3 is taken after intern year. Step 2 is taken after your clinical year. So as an international medical graduate, we absolutely need step 1 and we absolutely need step 2. Step 3 is not needed for an international medical graduate. In fact, almost nobody will have step 3 because that's taken after you've done actual clinical work as a physician in training for a while. And step 2 CS, by the way, is also mandatory and something that we want to see. The pass rates of step 2 CS are 95% plus, and remember, it's just a pass-fail test. But the US pass rate for step 2 CS is somewhere around 99%. The international pass rate drops substantially. And so that means that you guys may have to put in some work to really pass step 2, make sure that you're seeing standardized patients as they would expect you to see them in the States. It's a pass-fail test, so you don't have to worry too much about your exact number grade. In fact, you don't get a number grade, you just get a pass-fail, and so you're fine. You're going to pass as long as you've seen patients and studied for it, but you do have to put in some time. The other thing to keep in mind is that step 2 CS is only offered a few times a year in key locations, and so you have to plan ahead for that too. And so during your entire 4th year, when you're doing away rotations, when you're doing residency rotations, when you're doing interviews, you also have to figure out, hey, when am I going to take step 2 CS in all this? So again, all goes to early planning.
And this is, like I said, this is kind of far in the future, but I'd knock out CS as early as possible. It's just a headache to just study for. You literally just buy first aid, the CS book, and you just go through the 40 cases with your friends. And then you study for like 2-3 weeks, 4 weeks maybe, and then you just go take it in Atlanta or Philadelphia or Chicago or LA, and then you're done. That's it. It's a costly test too, so in a financial standpoint, you should probably plan for that. Plan for the CK and the CS. I think combined for those two, along with the flight to go take the CS and the hotel, it's going to be upwards of like $3,500. Right, so it's just a financial thing to think about as well.
So one of the things that we offer is help through Step 2 CS with interactive cases, as well as the ability to actually virtually do a standardized patient exam and those kind of things, which I think is very important if you're at risk for failing. So if you have any inkling that I'm not going to do on Step 2 CS, you should absolutely take advantage of that through MedSchoolCoach, because the worst thing that you can do, the big red flag, and it's actually physically a red flag that shows up on ERAS, on the program director application. Like, there's a red flag that shows up that says you failed one of the steps, okay? And so even if you pass the second time around, that red flag is a huge no-no, particularly for a international grad. Like, we want to see that, we don't want to have any question about your clinical ability to take care of patients, see patients, speak English, etc. So those things are extremely important. So for some people, it's really easy. You can get through it. It's not a tremendously difficult test, but it is a test that you should prepare for. And if you have any sort of hesitancy in the fact that you're going to pass it with flying colors, get the extra help, because you definitely don't want that red flag on your application.
Great. Any other questions? So you can upload an unlimited amount of letters, but you can only assign 4 letters to a program, per program. So you can have 10 letters, right? You could have 3 from an orthopedic surgeon, 3 from general surgeons, 3 from internal medicines. But like if I'm applying to, University of Florida internal medicine, I can only apply 4 of those letters that I've uploaded to that program at a time. Right, so the way you do it is if you'll ask your attending for a letter of recommendation, and then you'll go on ERAS and you'll put in his information or her information, and you'll put his or her email, and then they'll get a separate link to upload it, because you have to always waive your right, by the way. You always want to waive your right to see the letter, because you don't want, the program directors, I think they don't like to see that you haven't waived your right. So you want to show that you don't read the letter that they write about you. And then they'll get a separate link in their email that they can then go and upload their letter to your ERAS application.
And the people that you want to choose, obviously, number one are attendings. You're not going to get letters from people who are not attending. So residents and stuff that you worked with can help maybe craft a letter or talk to an attending about, hey, if I didn't have great interactions or I didn't have a lot of interaction with XO student, you can ask one of the residents who maybe you had a great interaction with that says, hey, I'm going to ask Dr. W to write me a letter. Do you mind talking to them about sort of how I performed? So you want them to be from attendings. Big name versus small name actually doesn't make much difference, because the reality is big name versus small name is not important, nor do I really care. I want a good letter of recommendation, a solid letter of recommendation that talks to your clinical skills, that sort of talks to the way that you performed on the rotation and is not generic. And that could come from a small name person or a big name person. It doesn't really matter at the end of the day.
The language that they use, and we'll get to your question, the language that they use in that letter, just kind of getting a feel for your preceptor, right? Is it someone that you think is going to write you a great letter or not? Like if you thought that your preceptor didn't like you that much, like he or she could put in that letter, they could just say he was an average student. I mean, you're not going to read it, right? So you have to be really careful about that. You had a question?
Will we be trying to get rec letters from our professors here?
No.
Okay.
Yeah, preclinical rec letters really mean nothing. And it wouldn't be, the dean's letter sort of encompasses some of the comments of preclinical years, and that's all we care about. The letters of recommendation should really come from a lot from the specialty that you choose. And so if you choose a specialty like IR, you're going to want at least one letter of recommendation from somebody in that field, and then maybe one from a medicine rotation because you spent more time, one from a surgery rotation. So it a little bit depends on the field that you choose, how many letters from each specialty that you're going to want to put in. In general, though, as you go through your medicine and you go through your surgery rotations, those are your major rotations. Develop relationships that you can end up asking for letters of recommendation from somebody from there.
Great.
So the question revolves around U.S. citizenship and residency. does it matter what you are? And the answer is yes. Unfortunately, it does matter because there are some hospitals that won't sponsor certain types of visas. And so depending on the type of visa you have, you can be sponsored or you can be unsponsored, and that makes a difference in if a program will accept you. The details of that are program dependent and sort of the ACGME funding decisions that the hospital has made at that level.
So even if you have a school, like the hospital doesn't have that sponsorship.
Yes, so you could be the most phenomenal candidate in the world. You could have cured cancer and AIDS at the same time. But if the hospital can't sponsor you, then they can't take you as a trainee, right? You're a hospital employee as a trainee. The hospital gets funding from the government to take you on, and that's actually a big deal for the hospital to get that funding. They get a certain percentage of your salary support. They get actually additional funding for being a training hospital. So they have to go through all these hoops to get that, and so they really need you to be funded appropriately or have the appropriate visa. And again, that's program dependent and sort of even hospital dependent, but also even program dependent on what the program will accept or not.
And that will require some research, but it's not information that you won't be able to find. Yeah. It's just going to take some digging. And in fact, you could just call them probably. If you like later on, just call the hospital residency program director. Just be like, "Do you guys sponsor visas from this country?" Right, and they'll tell you. Yeah. And you had a question.
How far into your rotation or after should you be asking for letter of recommendations? You don't want them to like forget you. And
Sure.
It's kind of this weird dance, right? Because you don't want to seem like you're jumping the gun, but then you don't want them to, you don't want to ask him like a year later and see. So what I did was at the end of the rotation, the way I did it, and like I said, this is different. I gave a thank you card with my picture on it, so they remember my face. I'm serious. I have thank you cards with my picture on it, and it has my email, my phone number, my school, and then literally everything. And it's a nice thank you card, and I gave it to them, and I said, thank you for a great time, and then. A few weeks after, I said, hey, I'd like to meet in your office, and then I'd bring a copy of my CV with me and a copy of my personal statement, with a paper just in case. And I said, I'd really appreciate a letter of recommendation from you. If you thought I did a good job and you think I deserve it, would you be willing to write me one? And I go, yeah. And then usually they'll say, just email me your stuff, but I bring it just to show that, you're prepared, right? And then, later on, once, residency applications are starting to come, just keep them in the loop, being like, hey, just letting you know that, you don't want to be too aggressive. You don't want to annoy them, but you just want to make sure that they have, they're still in mind and that they're still going to write you a note. A lot of preceptors kind of have like a pre-made letter. So you want to be careful about the preceptors. You want to kind of try to ask, around hey, was this guy a good letter writer? Like ask people who have been through that rotation, have had this preceptor. What do you think? Did you think that he wrote a good letter? Did you hear anything? There's a lot of ins and outs that you can get from students that have been through there, but don't the first day get there and be like, can you write me a letter, right? Wait till the end of the rotation. Make a good impression. Like I said, I gave a thank you card with a picture of myself so that they don't forget. A lot of the preceptors thought that was a really cool thing because they remembered my face. And then, later on, just ask if they can meet. Always ask in person if you can. Don't just do it over email, right? And then, keep them in the loop and then just email them before and say, are you still willing to write me one? Okay, great. Here's the link at ERAS. Please upload it. Right? Yeah.
So as somebody who's written a lot of letters of recommendation for students, I'll say that it's important to not ask right away, as Elias said. You definitely, I think the best time to ask is at the end of your rotation and say, hey, I'm going to be applying to X or Y. And this could be even early, right? I mean, you could be in your third year and kind of keep that person in mind and say, hey, I really enjoyed my rotation. Would you be comfortable writing me a strong letter of recommendation at some point? And I think doing something like a thank you card with your picture on it is actually a phenomenal idea because that might actually remind you, unless you're ugly, in which case, it might be a vibe. But
I touched it up, though, it's fine.
Yeah, Photoshop it heavily if you have to, right? It's important to sort of, we see a lot of students. I think your preceptors at SGU probably see even more students than I do and probably have less of a relationship with, because it's a lot of students come by and they're not necessarily at huge teaching hospitals, right? A lot of the rotations are at community hospitals where you're getting physicians who do some teaching, but are not necessarily teaching based, right? At an academic hospital like I'm at, my main job is to teach residents, fellows, med students. at other places. I know, like my father, for instance, is a physician in Brooklyn, and he gets international students who come through. His main job is not to teach. His main job is to take care of patients. So he may interact with these students for a very short amount of time, if at all. So kind of keeping that preceptor, keeping yourself fresh in that preceptor's mind with something like a card is nice to do, and asking them, relatively soon after to say, hey, I really enjoyed my rotation. Would you mind writing me a strong letter of recommendation? And hopefully they say yes. Some preceptors will even say, sure, just write a letter of recommendation, send it to me, I'll edit it, and that'll give me a good starting point. Others will take the time to maybe meet with you and understand a little bit more about you. It's a varied process, but staying fresh in mind and obviously being nice about it and not overbearing about it. And then, by the way, sending them a nice thank you letter at the end goes a long way. After they've written that letter, send them a thank you letter that says, just wanted to keep you in the loop. I matched at X or Y. It was really a pleasure working with you. Like those kind of things. Medicine is a small field at the end of the day. There are smaller fields within medicine, like IR, right? So if you had an IR letter and you match somewhere, you should absolutely send that person a thank you note once you've matched. Just say, hey, thank you so much. I matched into here. I just want to keep you in the loop, because you're going to see that person at conferences. That person may be at a fellowship that you want to eventually match into. That person may have a job down the line that you want to apply to. So keep those connections as warm as possible throughout is one thing I would say.
Any other questions?
So just to tell you guys a little bit about sort of what we do at Med School Coach, right? So Match a Resident First is a partner organization that has a great tool, as I mentioned, to sort of go online and put in your scores and put in what you want to go to, and it kind of spits out a bunch of programs. What we do at Med School Coach is we sort of hook you up with a mentor who has been a residency program director or has in a residency that you're sort of interested in, and they help walk you through the whole process, right? Because there's specifics, right? What does an IR program look for that's different than a surgery program? How are you going to craft your personal statement? Where are you going to apply to? Strategizing about your program list, any backups, those kind of things. That's what we do to really help you gain that extra foothold, right? And it's particularly important, I think, for international candidates to have that person helping them through. I mean, I'm not sure how the advising is here at U.S. schools. You typically actually have an advisor or a mentor within the field that you're going to go into, but I think that's a lot harder here to have because there's not a home base and a home clinical system.
So I actually am using the residency advising service. When trying to talk to SU about IR, like no one had any idea what was going on. Like they had no idea like what to do, where to apply, like what I needed to do. So I actually have a resident who's advising me, who's an IR resident at UCLA. He's through the company, and I probably bugged him so much he probably hates me. But he guided me through the whole process. He's going through my rank list. He went through we did a mock interview session right before my first interview. He looked at my personal statement, and honestly, he just got me right, and I felt confident going through my residency process. Like because every question I had that you can't really find on Google. Right, or there was a multiple answers. You just want to ask someone who's already been through it, right? So at least for IR, or like for some of those more competitive specialties, SU doesn't really give that much, leeway. Like Dr. Madden was pretty responsive when I used to call him, but he's an EM doc, and he's been a practicing EM doc for like 30 years now. So he probably doesn't know about a very young residency that just happened, right? But in terms of family, internal, and psych, SU might have a little bit more information about that. But for my sake, I needed an advisor because I had no idea what was going on.
Yeah. So that advisor can really walk you through the process and help you sort of figure out how to tackle it. And it really works because once you sort of have that person, then you can kind of assure yourself that you're going to match at the end of the day with it because they'll really guide you along the way. So it's been really nice talking to you guys. I hope this was helpful, and I hope you got some of your questions answered. We'll stick around for other questions at the end as well. Check us out at MedSchoolCoach.com. We help IMGs and SU students in specific with the USMLE prep, with residency advising. These are things that you guys could all definitely use. I mean, I'll go back to what we said yesterday, which is that absolutely 100% you can succeed coming from SGU. No doubt about it. But you guys probably have already seen some classmates who haven't succeeded, and you'll see more classmates who won't succeed as you go through the process. I mean, you want to end up being in his shoes, right? Having 18 interviews and matching at the place that you want to and having your choices. And you can do that only by sort of planning ahead and getting the help you need, because I think that a lot of people don't get that. They think it's too expensive. They don't think about it. They think that the school will provide it. And the reality is that